Assalamu alaikum jami'an. Thank you very much. So I'm going to go over a case and then we'll go stepwise and go through the clinical reasoning and what the evidence support whether this actually an important special population or not. So before I start, I just want to have two questions. First question, who did not have PPM in his career? Okay, so good, so most of you. Okay, my second question is that who thinks severe PPM is important? Okay, good. Very good, so we'll see if that's gonna change. Okay, so let's start with a case. A 72-year-old gentleman with severe symptomatic aortic stenosis, low surgical risk with a BSA less than 2, underwent SAPIEN 3 Ultra at 23, post-implant in the cath lab, you get an invasive mean gradient at about 4 millimeter. And the second day, your echo gradient the mean gradient is 17. And the echo calculated valve area is 1.4. In a month, the patient doing well, and the gradient start to creep up to 23. And the index AOA remains 0.72. So question you can ask yourself is that how you can explain these echo findings, discrepancy between the first guy. This is a very common scenario you face, right? And is that impactful in the long term? And does the patient have PPM? So why the discrepancy? And this is where I'm going to take you through, is that invasive assessment in the cath lab really directly measures the pressure compared to echo is taking a proxy, a surrogate of the pressure with a velocity. And that's where echo Doppler overestimate the pressure gradient compared to the cath in a normal functioning prosthetic valves. And that's the issue. And then you can ask you next question, okay, why you say echo is very reliable in diagnosing aortic stenosis? Because you say echo correlates very well in invasive hemodynamics, and that's what Braunwald and the whole historical features goes through it. And to answer that is different. Once you have a native aortic stenosis, you see the correlation is good. But once you're assessing a prosthetic valve, that correlation goes away. Hence the discrepancy between the cath and echo. And this is not new. This has been described a long time ago. And where the error in pressure gradient, of course there is measurement errors, but we understand there is a difference between the both modalities. And that comes with pressure recovery. And that's where pressure recovery plays a role in that. So in the cath, when you directly measure the pressure, you take the net between the valvular pressure gradient and the pressure recovery. And that's where the laminar flow after, in the ascending aorta, usually you have a stable pressure recovery. And echo, if you look at in the middle, it doesn't account for that, and that's a problem. And that's the same concept for the laminar pressure recovery and the laminar flow, straight, and that's where you measure the ascending. And we look in the live case yesterday, Dr. Shetty really highlighted the importance of positioning of your pigtails in the ascending aorta and in the LV to really have the accurate measurement of the gradient discrepancy. And if you look here, this is a very elegant slide. So if you look at the difference between cath, echo, and small versus large platforms, balloon expandable versus self-expanding, you can see if you take cath measurements, actually there's no much difference between the two, except an echo. An echo, when you have a small balloon expandable valve platform, that's where you're going to have the differences in the pressure gradient. So tell you, if you look at the cath, it's actually, there's no much difference. So the take-home message is that echo overestimated the gradients post-TAVI when compared to invasive, and, our surgical colleagues really faced that a long time ago, and they always face that issue. Remember the pressure recovery phenomena that it does not accounted in the echo. Panelists and the echo experts will talk about it probably more. And the highest echo cath discordance is seen in the small balloon expandable platforms. So I gave you the concept, the discrepancy between cath and echo, and now how you approach the patient with the scenario that we face. So as whenever you do a prosthetic valve assessment, you want to know, is it a structural issue or a functional issue, or non-structural? And once you rule out the structural issues, so you try to make sure that patient's not in high flow state, is it stenotic or not, before you reach out that the patient has patient-prosthesis mismatch. And that's out of the scope of the talk, but there's ways to go through to differentiate which and which. But in general, once you have confirmed that by echo follow-up, you have an increasing transvalvular gradient, is that accompanied by reduction in expected valve area? If it's not, you just follow the patient. If actually there is a change from the baseline in AOA or in the DI from the baseline, then you want to make sure assess them clinically and make sure there's nothing structural. If you think it's thrombosis, then you have a trial of anticoagulation. And if clinically he's really symptomatic or there's significant concerning findings, then you try to consider intervening. But otherwise, you really can't follow up the patient if patient clinically stable. And the phenomena of patient-prosthesis mismatch has been described a long time ago by Dr. Rahmatullah in 1978. And that simply is that the prosthesis that is implanted really, it doesn't meet the cardiac output of the patient need. And that's where the BMI plays a major role. And if you look at the different prostheses, the surgical ones, when you have where there's really the effective orifice area is compared to bioprosthesis, metallic valve, and the TAVI valve, you can't say why TAVI have a lower ppm compared to surgical valves in the past. How to diagnose ppm? So based on the gradient that you follow, then you, as we alluded earlier, that you try to identify the IOA index or predicted, what we're going to talk about. And in the VARC3 grading, you can look, they differentiate patients with BMI of less than 30 or more than 30, and based on that, you can't see the difference. It's arbitrary numbers, but that's when where they looked at. So the question back to, is ppm has an impact on mortality of the patient? Well, if you look at the evidence, the data is all over everywhere. So if you look here in the TAVI small registry, okay, you can say clearly there is a mortality rate higher with those patients with severe ppm. And if you look at the a meta-analysis, also they looked at, and it showed that severe ppm have increased mortality compared to non-severe. And you follow up in the small 2 study, the same goes for that. The severe ppm, you look at the divergence and the Kaplan-Meier and the severe ppm compared. And if you look at TVT registry, there was not really that really big impact on mortality compared in the previous studies that have been alluded. But if you look at the subset of patients who those have a low flow state or low EF, those are the ones that really have their mortality actually more than the others. And if you look at the Japanese population, the Ocean TAVI registry, And you can see in all four graphs, there is no difference between severe PPM compared to a non-severe PPM. So the reason of that, first of all, the definition was not really consistent in all the studies prior. Hence, the differences in the results of different studies, registries, randomized trials, and also the other reasons that's summarized by Dr. Hammerman very well, elegantly in this paper, is that the measurements are not consistent. It's not easy, because if you look at the core lab, when they do the echo measurements, it's not that reproducible every time. The effect of underlying flow state correction was not for obese patient with BMI, hence VARC3 really incorporated that. And the next question coming to your mind is PPM worse in women? And we know that small annulus, about 90% of them are women. And if you look at the partner 3 low-risk partner, actually women do worse than men once they have severe PPM. Then it comes the question about TAVI versus surgical aortic valve, and that's where small annulus concept been remedied, because once you have a small annulus, you have 3 ways in the surgical arena where you want to implant a sutureless valve, where you take out the sewing ring part, so you have a larger AOA, or you put a metallic valve, or you do an adjunctive technique where the surgeon do an aortic annulus enlargement. And we saw in SAVR before, there are more PPM compared to TAVI in the studies. But lately, the surgeons really kept up on bar by doing more aortic enlargement in those cases. Is there a difference between intraannular versus supraannular valve platform? Well, you can see in the balloon expandable and in the Navitor also in the intraannular, the commissural posts and sutures are anterior to the opening area, an example for the SAPIEN, compared to self-expandable valves, the posts are exterior to the opening area, so you have more AOA. And the OPRA TAVI registry that had been published recently, they looked into that, and you can see an effectiveness endpoint, there's no much difference. But if you look at the Ultra compared to the Pro Plus, there is a difference regarding severe PPM and increased gradient. And also PVL more with a self-expanding platform. But if you look at the study itself, about more than 3/4 of the patients are SAPIEN 3 Ultra 23. And that's what's driving the difference in the PPM. So how to prevent PPM? So you want to stratify. You want to predict that before you go ahead with deciding about your management strategy. So is a patient low for patient procedure mismatch, intermediate, then you try to go with a true size surgical aortic valve replacement or TAVI. If it's high risk, then you would consider using adjunctive techniques, for example, aortic annulus enlargement. And this is a beautiful algorithm published by Philip Paparot, where when you decide and based on your predicted IOA to go ahead with that. Skip for the, so aortic enlargement, maybe from my colleagues from surgery might comment on that, but it's really a concept of the aortomitral curtain, really, for example, this is the Y technique, and they try to put a graft, and that's about 3-4 millimeter increase in the AOA. We go back to the patient. Who would follow up the patient?
Add 1 minute if you can. That would be awesome.
Okay. Who would do
to
something
stick to
else?
that.
No? Okay. So we just follow the patient. We left him alone. As long as the AOA has remained stable, we left him alone for follow-up, and he's clinically stable with no any concerning symptoms. And my take-home message that cath, echo are really, there's discordance about that. So have a baseline echo before the patient gets discharged, so we can really follow up the patient properly. And small annulus, follow the algorithm approach. And if the patient is really, have a good surgeon, consider surgery in those cases rather than going with TAVI platform. Thank you.
Thank you.